So let me just ask a couple questions while you're thinking of some. Adrian, is there any way to prevent age-related changes in the bladder?
That's a very interesting point. I see actually in a rat model here presented here, caloric restriction is associated with some lack of accumulation of the architectural changes. I suspect that avoidance of obesity, maintenance of physical exercise, we will avoid some of the late life incontinence syndromes we see. Whether we actually reverse the age-associated physiology has yet to be really described. And in an incidental model of OAB, in both men and women, albeit, we can identify obesity, diabetes, low physical exercise, and a high glycemic diet as very positive risk factors. So from a public health perspective, diet exercise seems to be very attractive as a way of preventing late life problems.
Do we need to have a shorter trigger for prescribing the 5-alpha reductase inhibitors in elderly men or not?
I think it's the safest medical treatment. The risk of adverse effects is relatively modest. Those adverse effects that do arise with a 5-alpha reductase inhibitor are on aspects that are generally less important to the older man, though of course some older men are sexually active. So the use of a 5-alpha reductase inhibitor, the evidence that it seems to have a small impact on reducing acute urinary retention risk does potentially give us some clinical benefit. Whether that improves the pathophysiological progression, I would say, is extraordinarily doubtful.
Peter, do we need different parameters for normality in urodynamic studies in the elderly? What's okay and what's not okay? I mean, they're obviously not the same as they are in the 40-year-old population.
I think that normal low urinary tract function is what we all agree on. A bladder that fills until a social acceptable capacity and empties short, fast, and effective. And to add normal values in that is an elusive precision. And to add specific limits of normal for the aged, I think that is abnormal is abnormal, whether you're old or young. And I don't think, as long as there are specific treatments for categories of bladder outlet obstruction or categories of detrusor or contraction, it is meaningless to further subdivide. I think the diagnosis of bladder outlet obstruction on a urodynamic basis is a graded basis, a graded scale, but and there's all kinds of plausibility to select other treatments in the moderate grade than in the high grade, but not, unfortunately, not on good evidence and not on good evidence to relate on aging.
Yes, sir.
Arturo Garcia from Mexico City. Do you think there is a role for PDE5 inhibitors to modify the changes we see in the bladder derived from ischemia or the aging bladder? Is there a role for them?
Again, there's no evidence. There is a plausible hypothesis, but I suspect that the intervention or exposure might need to be prolonged to cause physiological rather than symptom-related change. Certainly, again, the duration of exposure is probably the important thing. We can change disease state, we can change symptoms, but are we altering the underlying pathophysiology? In the longer term, I suspect not.
Yes, sir.
Dr. Roger, if you have the prostate volume, IPP, with this we have 80% of probability to have obstruction. Do you need to go ahead and do pressure flow studies?
That's addressed to you. So while you're answering that, let me ask you, since the diagnosis of outlet obstruction depends really in large part on the detrusor pressure at peak flow, how do you make the diagnosis in someone with an underactive bladder?
If you have 80%, it's not enough to operate the patient.
Yeah. One thing is that not prostate volume alone or Qmax alone or post-void residual alone is very sensitive, nor specific for bladder outlet obstruction. It's the second best. And combine those together, there are some 5 or 10 articles out there in the literature saying that combining those values is of use. The other thing is about underactivity and bladder outlet obstruction. If somebody is able to void during urodynamics, there is bladder outlet obstruction, and that's very simple to define in an elderly man. So if he is able to void, however, contraction may be high or low, and that may be unrepresentatively low. And there's not a good way to know whether the bladder is contracting unrepresentatively low, other than asking the patient. Underactivity is a problem. If the patient has serious bladder outlet obstruction, I would direct the treatment to outlet obstruction. If the patient has no outlet obstruction and underactivity, I would hesitate to do something in the outlet, since when I make a scar there, the patient has not a bladder that opens that scar nicely. The bladder is unable to contract in the manner that the scar remains open, so he may run into more trouble than before.
Andrea?
Alan raised a good point. Peter, you showed us a slide that is misleading, and is the relation between the degree of obstruction and bladder contractility, because we measure both using pressure values. And this is what I alluded to in my previous moderation when I said that in physiology, contractility is different. It's not pressure, it's tension. You know, there's no way to be obstructed on urodynamics if you have a weak detrusor. So this is a problem that we haven't been able to solve over the last 20 years or so. You know, if you have a patient with a weak detrusor, he may be obstructed, but it will never show on urodynamics because he's unable to generate the pressure values that we use to diagnose obstruction. I don't have a solution, but at least, you know, we should point at this problem because it's out there and has been there for 20 years now.
No, not really. He said I can't answer that. So, but I can say something. And yes, if a bladder is unable to contract because of the circumstances during the test, so I have a problem. However, if somebody is able to void one drop on the basis of not of straining, but of his detrusor contraction, then I know whether it's obstruction or not, with a certain uncertainty. But I cannot diagnose whether the bladder is contracting good or not. So that's the problem. There is a problem in diagnosis of underactivity, and sure. And of course, those were the men able to void during urodynamics, and some could not be analyzed because they were not able to void. And I said this morning, that's about 10%. Even less. If I allow them to void in the preferred position, not force them to void in a sitting position, then almost 95 or 96% is able to void in a way that he says is representative.
Marcus, did you have something?
Yeah, we have quite a simplistic attitude towards underactivity, just simply saying, well, it doesn't generate very much pressure, and you end up with a poor flow. But we need to recognize that certainly in the healthy younger nervous system, there are feedback loops which in effect can increase the neural drive into the bladder wall to increase the power generated by the bladder. And that's of course extremely relevant if you pass urine in various different positions, standing, seating, lying down, underwater. You get a variation in the resistance, and yet this is completely straightforward for a healthy nervous system to deal with. It just increases the actual drive. But that sort of facility becomes weaker with aging and attrition of innervation of bladder wall and within the central nervous system. So the ability to compensate for perturbations such as position or underwaterness is lost. At the same time, of course, outlet resistance is increasing. As Peter very accurately says, we do get increased bladder outlet obstruction. And in women having stress incontinence surgery, we're definitely introducing some bladder outlet obstruction. So the normal, healthy younger woman will overcome her TVT without difficulty, whilst the older woman may struggle to do so and might be at risk of retention as a consequence. So in effect, underactivity is not just the absolute contraction generated, but it's also the ability to cope with variations in the situation, which I would say leads us perhaps to be thinking of underactivity as a relative insufficiency relative to the challenges it's got to face, which could be bladder outlet obstruction.
Marcus and then Adrian, are there receptor changes either in density or distribution or other physiologic changes that make an elderly man more or less sensitive to certain medications that the urologist might use?
Yeah, I don't know about quantification of receptor densities in older populations and certainly in specific areas of interest. For example, the bladder neck and the urethra for our alpha blockers. I surmise that the reduced autonomic innervation could lead to a denervation supersensitivity initially and then a gradual loss of expression. And likewise, in the bladder wall, there might be changes in muscarinic receptors, but seeing Carl-Erik Anderson shift from buttock to buttock on his seat makes me wonder if he might comment.
No, well, certainly aging centrally and to a certain extent peripherally is associated with the reduction in cholinergic system activity. The nerve density certainly changes. We know that from Chris's work that purinergic receptors probably become important pathologically rather than physiologically. So there are, I guess, some changes in older people. It's quite interesting to see, however, that in the OAB scenario, that older people are more likely to need pharmacological control than younger people, and that they, to achieve the same effect sizes, often need higher doses than younger people. As an interestingly, quite a recent article looking at we're using near-infrared spectroscopy with tolterodine, suggesting that tolterodine leads to an activation of the frontal areas which are associated with urgency suppression. So it might be slightly more complicated than we think.
Other questions, comments? Yes, sir.
Question for Dr. Marcus. We know that bladder ischemia, it's one of the factors for bladder symptoms. So we have now some procedures like prostate embolization. Do you think that this procedure would get worse the symptoms since it would take some blood from bladder neck or not?
Reporting the observational studies would suggest that it doesn't cause any significant effect at a symptomatic or functional level. They do attempt to be selective in their embolization, and you would anticipate that the vessels heading towards the bladder neck would be relatively preserved. You're not seeing retrograde ejaculation, though the extent to which this is investigated, I think, is limited and probably should be directly questioned. So I think the answer is probably that it doesn't have that effect, but if it does have that effect, then potentially that's significant in the longer term, very much so.
I think our time is up, so thanks to all the speakers and thanks to the audience for your attention.